Hi, this is Brian Kim. I'm going to share with you case number 121 in the Best Way to Do Cataract Surgery series. This is a 2 to 3 plus dense lens, and this patient's going to be receiving the Panoptix Toric lens. I'll be placing the lens at the 162-degree axis. You'll be able to see how I do this. And I'll be performing double chop, cross chop, mechanical fracturing techniques to disassemble this lens. By doing it this way, I'm able to reduce ultrasonic energy. And in my experience, I have clearer corneas post-op day one as a result, which results in happier patients, reduced risk for complications. And so you'll be able to see how I disassemble this lens, again, using the Panoptix Toric lens. So I've already pre-marked the eye with the patient upright in the pre-op area. So use a cotton tip to steady the eye, and then using a corneal marker to help me center and size the rexus. I make my paracentesis incision first on the right side and then the left side, making sure I'm parallel to the iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral lidocaine, and then some intracameral epinephrine, and then dispersive viscoelastic to coat the corneal endothelium and to flatten the anterior capsule. This patient has a really nice big pupil. This is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and when I'm ready to enter, I turn the eye towards me with the cannula, and I go in. I push some more viscoelastic, and these are the Haldi-Perkar cross-action forceps. And try to puncture the center very gently. I'm able to do so. I pull down. I grab the right side of the tear, which creates a nice flap. Make sure that the length of the tear is where I want it to be, which will dictate the size of the rexus. I go around circumferentially. And again, ever since I've gone to these cross-action forceps, I really haven't had any issues with the rexus trying to radialize. I have very good control of the size and centration. I'm not having to pull inward. I don't have any significant viscoelastic egress. I'm not having any major oar locking as I'm doing the maneuvers. I'm able to open the teeth nice and widely, and it's just really been a luxury to use these types of forceps for the capsular rexus. Burp some viscoelastic out, and this is the capsular fornix hydrodissection technique. Place a cannula out under the rexus edge contra-incisionally, point the tip down, get a nice wave, point the tip back up, decompress on the left side, and then hooking the lens on the right side, which allows it to spin. That hydrodissection technique is a game changer. It just really allows very consistent hydrodissection without any trouble or, failure of getting the hydrodissection. So go ahead and lift the incision with a chopper, going in with irrigation off, minimizing Decimase trauma. Removing the surface epinuclear material, placing the chopper under the rexus edge contra-incisionally, phacotyp vertically sub-incisionally. Crushing the lens. You see how dense that is. You can see there was no movement down or up. There's no translational movement as I'm doing the chop maneuver. Very safe on the bag, very, very safe on the zonules. I'm able to lift that first quadrant up, crush it between the instruments, and continuing to crush it into smaller and smaller pieces. By crushing it to smaller pieces, I'm able to emulsify it more efficiently and utilize less ultrasonic energy. So rather than just putting the pedal down and letting the phaco do the work, I believe in using mechanical forces to crush the pieces into smaller pieces. And as a result, not surprisingly, I have much clearer corneas by using this technique. Placing the chopper around the second quadrant, pulling it centrally and dividing that piece in half, using some vacuum to grab that piece, crushing the pieces between the instruments and emulsifying the lens pieces. See, the issue with using just ultrasonic energy at high vacuum and so forth, pedal to the metal, you're depending upon the cornea being completely coated with viscoelastic, and you just can't see it, so you're not quite sure. And the only way to know would be to just use tubes and tubes and tubes of viscoelastic to coat the cornea, and that's just not practical. And so when people say, oh, my corneas are going to be fine because I have viscoelastic covering it, you're just assuming that's the case. By doing the technique this way, you don't have to depend upon that assumption. And so by using minimal ultrasonic energy, as I do with my cases, I noticed much more consistent clear corneas. Before, when I did it the traditional way, sometimes I'd have clear cornea, sometimes I wouldn't. I'd always scratch my head and wonder, why is this cornea so cloudy? I thought I coated the cornea, everything was fine. So sometimes it was, obviously sometimes it wasn't, because I'll have, corneal stria, 2 to 3 plus central. And that's not just wound hydration, that's not just fluid. That's actually corneal edema due to damage to the corneal endothelium. And so I just don't have that same issue when I do cataract surgery this way anymore. Sometimes I'll have stria centrally, but that's usually for the extreme dense lens. But again, it would be like maybe traced to 1 plus, not like 4 plus stria. 4 plus stria is kind of a thing of the past with this type of technique. So we pretty much removed the endonucleus and now the epinucleus. Again, I'm protecting the posterior capsule with the chopper. I take the chopper out, push BSS in, take the phaco tip out. I go in with the INA handpiece. I start subincisionally removing the cortical material, going around circumferentially, peeling the cortex from anterior to posterior. It was already kind of loose, so it just kind of all flew out. Switch to polish mode, polishing under the rexus edge of the lens epithelial cells. Again, this really beautiful sized pupil in this case. I'm polishing under the rexus edge, but also the posterior capsule as well. Pulsing BSS into subincisional capsule fornix, which was clean here. Injecting some cohesive viscoelastic to fill the bag. And this is the updated Coke Singer sweep. It's got a big paddle, nice angle, and it's got a little bit of a sharper edge to the top, which more efficiently and effectively polishes the lens epithelial cells. Go ahead and inject a single piece acrylic Panoptix lens into the capsular bag, making sure the leading edge goes inside the bag. Quickly transitioning to the INA handpiece, activating irrigation once I go in, disengaging the haptics off the optic, going underneath the lens, tilting it, removing the viscoelastic from within the bag. Repositing the lens back into the bag, switching to polish mode, polishing under the rexus edge, polishing some more underneath the lens. I must have seen some fine lens material adherent to the posterior capsule here. So I like to go low mag when I do the toric now. So I aligned the toric marker with my marks that I made before, and I notice that the lens is like at 60 degrees. So I have a long ways to go. I need to get it to about 162 degrees. With irrigation on, I'm turning the tip of the INA tip down, and I'm just rotating at the optic-haptic junction and slowly rotating it to the 162 degree axis. So again, with the eye inflated, I'm able to very carefully and easily use the INA tip to hook the optic-haptic junction, and I'm rotating it to the appropriate axis in the clockwise manner. Once I get it there, I push BSS, come out with the INA tip. I thought I saw some more viscoelastic, so I went back in with the INA tip, removing more viscoelastic. And then I push BSS and I come out with the INA handpiece, and then I'll hydrate my incisions. So again, this is a patient with a 2 to 3 plus dense lens. This is a Panoptix toric lens with a 162 degree axis. I mark the patient in the pre-op area, get these beautiful marks, and then I position the lens to the appropriate axis, inflating the eye and rotating it to appropriate axis using the INA tip. Perform double chop, cross chop mechanical fractions. You could see when I do the fracturing maneuvers. All the maneuvers are within the horizontal plane. There's no downward force. The lens is not being pushed down. People were always worried in the past that I was pushing down on the lens. That doesn't really happen. I'm able to fracture the lens. There's no translational movement of the lens. It's not tilting, moving sideways or up or down. And I'm able to fracture the lens within the horizontal plane very efficiently into 3 pieces, and then using mechanical fracturing forces, crushing the lens between the instruments. And once the pieces are small, then emulsifying. By doing it that way, I'm able to limit ultrasonic energy. I have more consistent clear corneas, more consistent wows post-op day 1, and overall happier patients. And so this is why I think this is the best way to do cataract surgery. So I hope this was helpful to you, and I thank you for your attention.